Okay. All right. I think I'm online. It's interesting when you do the lectures or you do this quiz, what the computer does is take over the screen. So hopefully you're on. So you only could tell if you're on by checking somewhere else, but hopefully we're on. So let's get started. I have about a dozen cases. First case, abdominal pain. You're looking at the stomach, and the stomach folds are somewhat thickened. And if you keep looking, particularly in the fundus and body of stomach, there's thickening present. And then you look a little bit more, there's a little bit of air near the hilum of the liver, and there's a little outpouching of air here, thickening and particularly thickening the antrum. This is a small perforation. Antral thickening, wall thickening in the stomach can be inflammatory, gastritis, can be caustic, can be neoplasm, can be varices. But if you look carefully, you're saying there's wall thickening, and to me, I'm really worried about a neoplasm, and maybe that's why it perforated. Maybe there's an infiltrating gastric cancer. This patient eventually will undergo endoscopy, and it was ischemic gastritis. Tough call, inflammation, surely ischemia, without seeing anything in the vessels were fine, can be real challenging. And this was a really challenging, atypical case. Obviously, the free air helped you. Abdominal pain distension, ascites, marked thickening of the peritoneum, on the cinematic, the wall thickening of the stomach and infiltration, which gives you the look of linitis plastica, this infiltration of the stomach in its entirety, the ascites, the omental caking. Yes, you can think about metastasis, maybe ovarian, involving the stomach and abdomen. But when you look at the entire picture, it really looks like this linitis plastica of the stomach. Could be breast cancer metastatic, could be primary. This was a primary, and we'll look at the choices. Primary gastric cancer. Wonderful example of linitis plastica. Wonderful example of carcinomatosis. Abdominal pain. Large mass arising off or extending to the stomach, kind of cystic. And you can see it really nicely coming off the greater curvature on the coronal views. Lobular masses off the stomach, first thing and second thing and third thing I think about are GIST tumors. GIST tumors can be solid, they can be slightly vascular, it can be cystic, as in this case. It can extend intraluminal, the intraluminal, extraluminal, or even only intraluminal. The most would be extraluminal. And so in this case, lobular mass coming off the stomach, it's not a mesenteric cyst, it's not a pancreatic lesion, it's not a lymphoepithelial cyst. Nicely shown the cinematic. This is a great example of a gastric GIST tumor. Okay. Another mass. Look at the stomach, thickened folds, and what a surprise, the bunch of stomach cases to start. These are nodules in the lung. Those are mets on the pleura. I'll tell you, this could be a hemangioma, but could also be a vascular metastasis. And you can see multiple vascular lesions. Again, hemangioma is a thought, but what if I told you that was metastatic? Now you have spleen. Now you have lung. You have an absent right kidney. Aha. Left kidney, no right kidney. And this was resected. It's not congenital absence, obviously. And now in the stomach, you see a polypoid mass, which is enhancing. You can think about an adenoma. You can think about a carcinoma. You can think about a number of things. But all of a sudden, when you see an absent kidney, renal cell gives mets that are vascular. It can go to stomach, go to small bowel, obviously adrenal, pancreas, contralateral kidney, and spleen are all possibilities. And this was a clear cell renal cell carcinoma metastasizing to spleen and stomach and lung. What a great case. Markedly thickened gastric fold. That's a lot of gastric fold thickening. It's the most impressive appearance you're ever going to see. And when you look at the proponents anteriorly, it kind of almost looks like a cross section from a head CT. And I'll tell you why that's important in a moment. Again, lymphoma, severe gastritis, bad carcinoma, but what else could it be? the classic history of Menetrier's disease, uncommon but markedly thickened gastric wall. And if you look, it has this cerebriform rugal folds, brain-like, classic for Menetrier's disease. Proximal stomach, as in this case, is the most common zone of involvement. Often, as in this case, antral sparing, preserved wall stratification, and smooth muscle, serosa. Again, just a very impressive example, something we don't see very often, at least in our practice. GI bleed. There's a mass in the stomach. It's enhancing. It's submucosal. Could be a met in theory. Could be a glomus tumor. Could be ectopic pancreas, though usually it wouldn't be submucosal. Could be a leiomyoma. There it is again, protruding in the lumen on the virtual images of the stomach. And this was a glomus tumor. Again, submucosal enhancing. Glomus is in your differential. Incidental finding. Based on what I showed you before, this should be a GIST tumor. Exophytic lesion also coming intraluminal, nicely shown, homogeneous, and my best bet is GIST tumor. This needs to come out, it's in the 5 centimeter range. You worry about malignancy developing over time. But what if I said this wasn't a GIST tumor? This was a schwannoma. I've seen several cases of schwannomas. I will admit it's uncommon, but it's in that differential. Back pain, large aortic aneurysm with stents. Then you see a leak. Then you see the duodenum and you see air. This is a classic appearance of a aneurysm eroding into the duodenum in patient with severe GI bleeding, aortoenteric fistula. Typically involves the duodenum because the duodenum sits above the aorta in the retroperitoneal space. And when you start seeing those air bubbles and you see the duodenum draped, your diagnosis is indeed made of aortoenteric fistula. There was recently a nice article about this in Emergency Radiology. You may see contrast extravasation, the fistula's tracked with the air. Again, you can see air in a graft for a few weeks perhaps, but not this late. And again, the bowel wall thickening in the classic location. A really nice example of a aortoenteric fistula. This article was recently published. It's well worth reading, okay? Presentations variable. GI bleeding is the most common manifestation, which may be intermittent or massive. If it's massive, the patient could die from bleeding to death. And again, it's not common, but you need to look at it. Anyone who's had a graft, now it could just be an aneurysm or pseudoaneurysm, which can erode into bowel. So you need to be very, very careful. And again, most common cause, atherosclerotic penetrating ulcer. Very nice example. Dysphagia, there's a mass behind the trachea, pushing on the esophagus. It's somewhat enhancing. Could be a large node, could be extension of the thyroid, but it was not coming from the thyroid. Could it be duplication cyst? It's solid. If it was a leiomyoma at the esophagus, you would see the esophagus somewhat dilated. There it is in the sagittal view, this oval mass, nicely pushing on esophagus and trachea. And this was a paraganglioma. Again, uncommon. Paragangliomas we think about in the abdomen, which are extraadrenal theos, but they can occur in the chest, particularly middle and posterior mediastinum, as was the case here. Chest pain. There's a mass by the right breast rather, extending toward the pectoralis major muscle. You would say breast cancer. You would say abscess. There it is again with a calcification. Could be an abscess in the right scenario, but it's solid, enhancing, and really PET avid. There's a node that's PET avid as well. Here's a full scan with also some increased avidity in the left neck. And what was this? An angiosarcoma of the breast. We're sitting in July 2026. Within the last month, an article published in Radiographics had a very nice description of angiosarcoma of the breast. but they didn't have such a nice image. Okay, and here's the article. Breast sarcomas are rare. They account for less than 1% of all breast cancers and less than 5% of CTisus sarcomas. And angiosarcs are the most common type of breast sarcoma, and every type is indeed rare. It can be found in the non-irradiated breast of women without predisposing factors or a bit younger. Angiosarcomas can occur anywhere, including in the breast, in an area that's been radiated, particularly if it's been over-radiated. Okay, adrenal. Mass left adrenal of calcification, which enhances. It's large. It's not, what could it be? It could be an adenoma. Size, you can have bigger adenomas. But then when you look at the MIP imaging, you see the neovascularity. When you see neovascularity, it ain't any adenoma I've seen. Got to be thinking about a carcinoma. Couple more MIP images. In this patient with Cushing's, again, Cushing's is a most common functioning type of adrenal tumor. It could be due to adenomas. It could be due to cancer. Based on size and enhancement, you have to worry about cancer. And that was indeed a primary adrenal cortical carcinoma. Another example, weight loss and a large mass, which is in the region of the right adrenal gland. It's vascular, it's necrotic, nicely shown in the coronal views and the 3D volume rendering, inseparable from the liver, because if you had a really imagination, you could say, well, maybe it's a hepatoma coming off. Well, when you look at all the images, it's really in the adrenal bed. This is a classic appearance for a primary adrenal cortical carcinoma, ACC with necrosis, neovascularity, all particularly well shown on the cinematic rendering. Great case. Also, there was IV invasion. Incidental right adrenal lesion. Look at this 3.3 centimeter mass, how vascular it is. That's the key. What could be vascular? Well, rarely you can get hemangioma. You could get metastasis from renal cell to the adrenal, which can be vascular. You can get neuroendocrine tumors, but the classic vascular adrenal lesion is a pheochromocytoma. Clinical history, usually the patient's hypertensive. Look at the patient's labs, the metanephrines. Classic pheochromocytoma. And that, my friends, is the end. You've gotten 17 minutes of non-AI generated information. Hopefully you enjoyed it. Hopefully it was helpful. And hopefully you have a great day. Bye, everybody.